Welcome to the Deep Dive, the show where we aim to cut through all that information overload and really distill the critical insights you need. Today, we're diving deep into something you see all the time in practice, something that often looks quite simple on the surface: the ganglion cyst. You've definitely seen them, maybe even thought, just a lump. But actually, as we'll unpack, there's a fair bit of nuance in the pathology, the diagnosis, and managing them effectively for our patients. Our goal today is to equip you with that sort of advanced understanding, those practical pearls that go beyond the basics so you feel really confident handling these cases.
Indeed. And while ganglion cysts are incredibly common, they are the most common soft tissue mass we see in the hand and wrist. Their generally benign nature can sometimes mean we underestimate their clinical impact. For us as practitioners, it's vital to remember that while they aren't usually malignant, they can cause significant pain, real functional impairment, and frankly, a lot of anxiety for patients. So that really demands a comprehensive evidence-based approach and, well, a compassionate one too. That's what we'll aim for today.
Okay, let's get right into it then. When a patient comes in, points to this lump, often on their hand or wrist, what exactly are we looking at? Anatomically, physiologically, what is a ganglion cyst?
Right. Fundamentally, it's a benign sac filled with fluid. Technically, it's a pseudocyst. That means it doesn't have a true epithelial or synovial lining like a proper cyst does. The analogy I find most helpful, especially for patients, is to picture it as a sort of balloon on a stalk. And that stalk isn't just descriptive, it's the crucial bit. It's a narrow neck connecting the cyst back to an underlying joint capsule, or maybe a ligament, or even a tendon sheath that grows outwards from there. Understanding that connection is absolutely key to grasping why they can recur.
Okay, that connection point sounds critical.
Yeah.
And the fluid inside, what's that like?
Yes, the fluid is quite characteristic. It's typically very thick, clear, and quite slippery or viscous. It's a mucin-filled substance, almost jelly-like sometimes. Compositionally, it's very similar to the synovial fluid that lubricates our joints naturally, just much more concentrated, much thicker.
That balloon on a stalk image really helps visualize it and highlights that connection. You said they're commonest in the hand and wrist. Can you give us a bit more detail on the typical locations? And are they always just there, or do they change?
Absolutely. Location-wise, the vast majority, we're talking around 70%, pop up on the dorsal aspect, the back of the wrist. Very often, they originate specifically from the scapholunate articulation, that key joint between the scaphoid and lunate bones, which is so important for wrist movement and stability. That's your classic dorsal wrist ganglion.
Right, the commonest one we see.
Exactly. Then perhaps around 20% develop on the volar side, the palm side of the wrist. These tend to arise from the radiocarpal joint, the main wrist joint, or perhaps the STT joints, the scaphoid trapezium trapezoid joint complex. What's really important about these volar ones is that they're often a bit off-center, maybe towards the base of the thumb, and crucially, they lie very close to important nerves and blood vessels. We'll come back to why that matters later.
Okay, noted. Volar ones are near the plumbing. What about further down?
Yes. Moving into the fingers, about 10% are found at the base of a finger on the palm side. These are often called volar retinacular ganglions. Now, these are a bit different. Unlike the sometimes softer wrist ganglions, these tend to be quite small, often just pea-sized, but they're typically very firm and noticeably tender, especially when the patient grips something or presses directly on it. They can be surprisingly painful for their size.
Small but mighty, potentially.
Precisely. And finally, there's the dorsal DIP joint ganglion, the distal interphalangeal joint. We usually call this a mucus cyst. You find these right at the end joint of the finger, typically on the nail side. And while the hand and wrist are definitely the hot spots, it is worth remembering they can pop up elsewhere, less commonly, mind you, but you can see them around the knee, the ankle, other joints too.
And the dynamic nature you hinted at, do they fluctuate?
Yes, this is one of the things that often puzzles patients the most. They absolutely can vary in size, quite significantly sometimes. It's very characteristic for them to increase in size with activity when the joint is being used more, and then decrease, sometimes quite dramatically, with rest. Patients will often say, "It shrinks when I take it easy, but swells up after I've been busy." And perhaps even more confusingly for them, they can sometimes appear and disappear completely, seemingly spontaneously, over weeks, months, or even years. Causes a lot of uncertainty.
That fluctuation, even vanishing entirely, certainly makes them seem quite elusive. Which brings us to the big question: what actually causes them? What triggers their formation? Is there a particular group more likely to get them, and what underlying factors might be at play, especially given that unpredictable behavior?
Well, it's still an area where we don't have all the answers, I'm afraid. The exact cause, the precise etiology, isn't fully understood, which can be frustrating. But we do have some strong leading theories.
Such as,
One major theory involves trauma. Not necessarily a big, single injury, but more likely repetitive microtrauma or chronic irritation to the joint capsule, ligament, or tendon sheath involved. Think about the constant, low-level stress from everyday movements or specific repetitive tasks. This ongoing irritation might trigger a degenerative process that leads to the cyst forming.
sort of wear and tear, but on a micro level.
Exactly. Another important concept is mucoid degeneration. This involves changes within the connective tissue itself. Essentially, under chronic stress, the collagen fibers in the joint capsule or sheath can become disorganized. The local cells, the fibroblasts, then start overproducing substances called mucopolysaccharides, these complex sugars that attract water. This creates a localized pocket of gelatinous material which coalesces to form this cyst cavity. It's like the tissue is breaking down and forming this jelly-like substance in response to irritation.
So less of a simple outpouching, more of a degenerative change.
That's one strong theory. And then there's the synovial herniation idea. This suggests that perhaps a weakness develops in the joint lining or tendon sheath, allowing a small bulge or hernia of the synovial tissue to push outwards. This herniated sac then fills with fluid. It's quite possible, even likely, that different mechanisms are involved in different people, or perhaps it's a combination of factors, microtrauma leading to degeneration, which then allows herniation.
Okay, so the why is still a bit murky. What about the who? Are there clear patterns in who tends to develop these?
Yes, demographically, we do see some clear trends. They are most common in younger people, typically peaking between the ages of 15 and 40. We also consistently see a higher incidence in women compared to men. The exact reason for that isn't fully established. Perhaps hormonal factors affecting ligaments, or maybe differences in activity patterns, we're not sure. And certainly we see them frequently in groups like gymnasts or other individuals whose activities involve repetitive stress or loading of the wrist. Think repeated hyperextension or forceful gripping. That strongly suggests a link with overuse or repetitive strain, which fits nicely with those microtrauma and degeneration theories we just discussed.
That link to repetitive strain seems quite intuitive, especially for athletes. But are there any specific types of ganglion cysts that show a stronger link to other underlying conditions or perhaps different age groups?
Yes, absolutely. And this is a really key point for diagnosis. Those mucus cysts we mentioned, the ones at the end joint of the finger, the DIP joint, have a very strong, very consistent association with underlying osteoarthritis in that specific joint. Unlike the ganglions typically seen in younger people, these mucus cysts are much more common in older individuals, usually women between 40 and 70 years old. So the presence of a mucus cyst is a big clue that there's underlying degenerative joint disease. The arthritic process itself likely causes changes in the joint capsule and fluid dynamics that predispose to the cyst forming. Recognizing that link is vital because it influences how we manage it. We might need to address the arthritis as well as the cyst.
Right, so a mucus cyst points towards underlying arthritis in that older age group. Very useful distinction. So we have a good idea of what they are, who gets them. Let's bring this right into the clinic room. Patient presents with a lump, asks, "Doc, what is this?" How do we approach the diagnosis? How do we nail it down as a ganglion? And importantly, rule out other things it might be.
Right. This is where good clinical skills are paramount. The most obvious presenting symptom, of course, is the lump itself, a visible or palpable mass. And as we said, the size can vary hugely, from tiny, like a pea, maybe only noticeable on careful palpation, up to something quite large, golf ball sized, or even bigger. But it's also crucial to remember the possibility of occult ganglions. These are smaller cysts hidden deeper under the skin, not easily seen or felt, but they can still be a very real source of pain or discomfort, often presenting as unexplained wrist pain.
And symptoms beyond just the lump. Pain,
Okay,
function.
definitely. While many are truly asymptomatic, just a lump, the patient notices pain, aching, or tenderness are very common complaints, especially with activity or direct pressure. If the cyst gets large enough, or depending on its exact location, it can certainly press on adjacent nerves. This can cause neurological symptoms, tingling, pins and needles, numbness, or even muscle weakness in the nerve's distribution. That needs careful assessment. Sometimes they can physically impede joint movement, leading to stiffness or a reduced range of motion, limiting activities. And we shouldn't underestimate the cosmetic concern. Even a completely painless lump can cause significant anxiety or unhappiness for the patient, affecting their self-image.
Those are all really important points, especially the occult ones and potential nerve issues. So when we examine the patient, beyond just seeing the lump, what are the key steps? What are we looking for?
A methodical examination is key. We always start with a thorough history, of course, asking, how long has it been there? Has it changed size, come and gone? What makes any pain worse or better? Any history of injury? And importantly, what's bothering the patient most? Pain, function, appearance. Then on physical examination, palpation is crucial. Ganglions typically feel firm but well circumscribed, meaning you can feel distinct borders. A key finding is their mobility, or rather lack of it relative to deep structures. They usually feel fixed to the underlying joint capsule or tendon sheath where they originate, but they should not be fixed to the overlying skin. You can often move the skin over the lump. That helps differentiate them.
Okay, fixed deep, mobile superficially. What else?
Then comes the classic test, transillumination. Simple but very effective. You shine a bright pen light or other focused light source directly against the lump in a darkened room. If it's a fluid-filled cyst, the light will shine through it, it'll transilluminate. A solid mass, like a tumor, won't. It's a quick way to confirm its cystic nature.
Right, the pen light test.
Ah,
Still very useful.
absolutely. Now, specifically for volar wrist ganglions, those on the palm side, a vascular assessment is non-negotiable. You must perform an Allen's test. As you know, this checks the collateral blood flow to the hand via the radial and ulnar arteries. It's essential because these volar cysts can sit right next to the radial artery, sometimes even encasing it, and also near major nerves. Doing an Allen's test before considering any procedure like aspiration is vital to ensure the hand has adequate blood supply from the other artery if the one near the cyst were inadvertently damaged. Safety first.
Crucial point for volar cysts. And any specific signs for mucus cysts at the fingertip?
Yes. For mucus cysts, look closely at the fingernail. Chronic pressure from the cyst on the nail matrix underneath can cause a longitudinal groove or depression in the nail itself. That's quite characteristic. Also examine the skin overlying the mucus cyst. It can become very thin, almost translucent, and quite taut. This makes it prone to rupturing, sometimes spontaneously or with minor trauma. And if it does rupture, and that thick, jelly-like fluid leaks out, that is an urgent situation. It creates a direct communication between the outside world and the underlying arthritic joint. The risk of bacterial infection, septic arthritis, is very high, and that can rapidly destroy the joint. So a ruptured mucus cyst needs immediate attention, usually antibiotics, potentially urgent surgical cleaning, a washout.
That's a critical warning about ruptured mucus cysts. So clinical assessment is key. But what if we're still uncertain or need to rule out other things definitively? What role does imaging play?
Imaging definitely has its place, often as a supplementary tool. X-rays are important, but not primarily to see the cyst itself being soft tissue. It won't show up well on an X-ray. Their main value is to look for other things. They help rule out underlying bony issues like arthritis, especially important with mucus cysts, or fractures, or even a bone tumor that might be presenting as a lump. So X-rays are really for assessing the bone and joint context.
Okay, x-rays for bones and joints. What about visualizing the cyst itself?
For that, ultrasound is extremely useful. It's excellent at differentiating a cystic structure from something solid, like a tumor, or from a vascular structure, like an aneurysm, which might mimic a cyst. On ultrasound, a ganglion typically shows up as a well-defined anechoic lesion, meaning it looks dark, because it's filled with uniform fluid, often with some posterior acoustic enhancement behind it. Ultrasound is also brilliant for finding those hidden occult ganglions that are causing pain but aren't easily felt. And, as we touched on, it's invaluable for guiding aspiration procedures, allowing you to see the needle going into the cyst and, crucially, helping you avoid hitting nearby nerves or blood vessels, especially in tricky spots like the volar wrist.
So ultrasound is great for confirmation and guidance. When might we need an MRI?
MRI provides the most detailed view of soft tissues. It can clearly show the cyst, confirm its fluid nature with specific signal characteristics, and precisely map out its stalk in connection to the joint or tendon sheath. It's particularly helpful if the diagnosis is unclear after clinical exam and ultrasound, perhaps if symptoms are atypical, or if we suspect an occult cyst that ultrasound couldn't pinpoint. MRI can also reveal associated problems like ligament tears, CAR-T, scapulinate ligament injury, which can sometimes coexist with dorsal wrist ganglions, or other subtle injuries contributing to the patient's symptoms. However, it's important to stress that for most typical, straightforward ganglion cysts diagnosed clinically, advanced imaging like MRI often isn't necessary before starting initial treatment. Clinical assessment and maybe ultrasound are frequently enough.
Right, reserve MRI for the more complex or uncertain cases. Okay, so we've confidently diagnosed it. What are the treatment options on the table? What's the usual first step? And when do we think about escalating?
The approach really depends on the symptoms and the patient's preferences. For many, especially if the cyst isn't causing pain or functional problems, The initial approach is actually non-surgical.
So just watching it is a genuine option, even if there's a visible lump.
Absolutely. Observation or watchful waiting is often the safest and recommended first-line approach for asymptomatic or minimally symptomatic cysts. And the key message for patients here, which often reassures them greatly, is that a significant proportion of these cysts resolve on their own, spontaneously. Studies suggest rates of 30–50% in adults, and even higher, perhaps up to 76%, in children within a year or so. It's vital to explain that they are benign, not cancerous, and leaving them alone if they aren't causing problems carries no known long-term harm. That removes a lot of anxiety.
That's a really important point about spontaneous resolution. What about other conservative steps if observation isn't enough or if it is symptomatic? Splinting.
Yes, immobilization can be very helpful for symptomatic cysts, especially those aggravated by wrist movement. Using a wrist brace or splint, maybe for a few winks, can reduce the irritation and activity-related pressure. By resting the joint, the cyst might decrease in size, and the symptoms often settle down. Once the pain improves, it's usually followed by gentle range of motion and strengthening exercises to get function back and prevent stiffness.
Okay, rest and splinting. What about aspiration? Actually drawing the fluid out. It seems intuitive, but you hear mixed reports about how well it works long-term.
Aspiration is definitely a common next step if the cyst is painful, limiting function, or causing significant cosmetic concern. The procedure itself is usually straightforward in the clinic. We numb the skin, use a sterile needle, often a slightly larger bore needle because the fluid is so thick, puncture the cyst, and withdraw as much of the gelatinous fluid as possible. As we mentioned, ultrasound guidance can be very helpful here, especially for volar cysts or deeper ones, to ensure accuracy and avoid adjacent structures.
But the recurrence.
Yes, that's the major caveat with aspiration. You're spot on. We had to be very upfront with patients about the high recurrence rate. It's typically around 50%, maybe even higher in some reports. The weed analogy works well here. Aspiration's like cutting the top off the weed. It removes the visible part, the fluid, but it doesn't remove the root, that connection or stalk back to the joint or tendon sheath. So the fluid often reaccumulates. That said, it's a low-risk procedure, provides temporary relief for many, and avoids surgery initially. Some evidence suggests that repeating the aspiration maybe 2 or 3 times might increase the long-term success rate somewhat, perhaps up to 85% in some series, but recurrence is still common. It's most often used for dorsal wrist ganglions. Volar wrist ones, as we keep saying, are much trickier due to the proximity of the radial artery, and nerve's aspiration there needs extreme caution, ideally with image guidance.
Given that 50% or higher recurrence with aspiration, when does surgery excision become the main recommendation? What tips the balance?
Surgery, meaning complete excision of the cyst, is generally recommended when those non-surgical options haven't worked. So if symptoms like pain or functional limitation persist or worsen despite rest, splinting, or aspiration, or if the cyst keeps coming back after aspiration and remains problematic, or if the cosmetic appearance is unacceptable to the patient and they desire a more definitive solution, understanding the risks involved.
And what's the goal of the surgery? How is it actually done?
The absolute key goal of surgical excision is complete removal. And that means removing not just the fluid-filled sac, the balloon, but critically, tracing it back to its origin and removing the stalk or root where it connects to the joint capsule or tendon sheath. This often involves excising a small cuff of that capsule or sheath tissue at the base to really get rid of the origin point and minimize the chance of it growing back. We can do this through either an open incision or using arthroscopic techniques, keyhole surgery. Open surgery gives direct visualization, the traditional standard. But arthroscopy, especially for dorsal wrist ganglions, is becoming more popular, potentially smaller scars, maybe less pain, quicker recovery for some. The choice depends on the cyst's location, size, surgeon's preference, and experience.
Could you perhaps walk us through a typical surgical example, say, for one of those common little ganglions at the base of the finger?
Certainly. Let's take the pearl ganglion, or flexor tendon sheath ganglion, at the A1 pulley. Very common. This is usually a day case procedure, often done under local anesthetic, maybe with a tourniquet on the arm for a clear view. A small incision is made over the lump. Careful dissection is needed because the digital nerves and arteries run right alongside these structures. You have to protect them meticulously. The cyst is identified, usually stuck to the tendon sheath. The crucial step is to find its base, where it originates, and excise it completely, often taking a small window of the A1 pulley sheath with it, which doesn't usually affect tendon function. Then meticulous closure. Precision and protecting those nerves and vessels are paramount.
And after the surgery, what's the recovery like? What should patients expect?
Post-op care is crucial. It's usually outpatient surgery. They'll go home with a dressing, maybe a supportive bandage or splint initially. They should expect some soreness, swelling, and discomfort for the first few days to a week. Pain relief medication is usually provided. Elevation is really important for the first 5 days or so. Keeping the hand raised above the heart level helps massively with swelling and pain. We encourage gentle finger movements starting almost immediately from day one, just bending and straightening to prevent stiffness and stop tendons or nerves getting stuck in scar tissue. The wound needs to be kept clean and dry until the stitches come out, typically around 10 to 14 days. No soaking the hand. Return to normal activities varies. Driving might be possible after a week or so, once stitches are out and they feel in full control. But heavier activities, manual work, sports that usually needs a longer wait, typically 4 to 6 weeks, sometimes more, to allow full healing and avoid irritating the surgical site. Communication with the surgeon about specific restrictions is key.
Okay, that gives a clear picture of treatment. Now, looking at the bigger picture, what's the realistic long-term outlook? And what potential complications do we need to be aware of and discuss with patients?
Overall, the prognosis is generally very good. Ganglion cysts rarely cause any permanent major disability. Most symptomatic ones that don't disappear on their own will respond well to treatment, bringing significant symptom relief.
But recurrence remains a possibility, even after surgery.
Yes, recurrence is the main thing patients worry about, and we need to be realistic. As we said, aspiration has a high recurrence, maybe 50% or more. Surgical excision offers a much lower recurrence rate, but it's not zero. The figures vary quite a bit in the literature, maybe anywhere from a low of around 4% up to 10%, or even higher in some older series, or for specific locations, perhaps up to 15–20% for volar wrist ganglions. Factors like the cyst location, surgical technique, how thoroughly the stalk was removed, and surgeon experience all play a part. And sometimes what seems like a recurrence is actually a new cyst forming nearby. If it does recur and cause problems, revision surgery is possible, though potentially more complex.
Understood. And besides recurrence, what are the other potential bumps in the road, the complications associated with treatment, especially surgery?
Complications are generally uncommon, but they can happen. With aspiration, the main risks, though rare, are infection at the injection site, or injury to a nearby nerve or blood vessel again. That risk is higher with volar wrist aspirations. With surgical excision, potential complications include infection, though the risk is usually low in elective hand surgery. Neurovascular injury is a definite concern. Damaging small sensory nerve branches, leading to numbness or painful neuromas, is a risk, especially with dorsal wrist surgery, where superficial radial nerve branches are vulnerable. Injury to the radial artery is the main vascular risk, particularly with volar cysts. Patients can also experience postoperative stiffness or some loss of wrist motion, which is why early mobilization is so important. Persistent pain at the surgical site can occur. And rarely, especially with dorsal wrist surgery near the scapholunate joint, the ligament itself could be inadvertently injured, leading to potential instability down the line.
And you mentioned specific risks with mucus cysts earlier.
Yes, it bears repeating for mucus cysts. The big risk is infection if that thin skin breaks. If it ruptures and leaks, bacteria can get straight into the underlying arthritic joint. That's septic arthritis, an orthopedic emergency requiring urgent antibiotics and often surgical washout to prevent rapid joint destruction. It's critical patients understand this risk and seek immediate help if a mucus cyst ruptures or looks infected.
Absolutely critical point. This has been incredibly comprehensive, really getting into the weeds of diagnosis and treatment. Thinking beyond the immediate procedure, what about preventing recurrence, managing patient expectations and anxieties, and what's happening on the research front?
Great questions. Looking at the broader picture, in terms of preventing recurrence, since we don't fully know the exact cause, true prevention is difficult. But we can advise on managing risk factors.
What sort of advice can we give patients for managing at home or modifying activities?
If overuse seems to be a factor, advising patients to modify or reduce repetitive movements that stress the wrist or finger can help. Maybe changing technique in sports or adapting workstations with ergonomic tools, keyboards, mouse rests. Avoiding very heavy lifting if it clearly aggravates the cyst. For home symptom management, simple things like heat or cold packs can offer temporary pain relief. Wrist braces or wraps can provide support and reduce stress during activities. Gentle exercises, wrist curls, grip strengthening might improve stability. And reminding patients to take regular breaks during repetitive tasks is often beneficial.
And addressing the emotional side, you mentioned anxiety earlier. How significant is that?
It can be very significant, and we mustn't dismiss it. Even a painless lump can cause real cosmetic distress, affecting self-esteem. If there's pain or functional limitation, that naturally leads to frustration, anxiety about work or hobbies, the uncertainty around treatment, the risk of recurrence. That whole decision-making process can be stressful. So acknowledging these concerns, providing clear information, discussing options thoroughly, and involving the patient in decisions, that shared decision-making approach is crucial. It helps alleviate anxiety and empowers the patient.
Really important to consider the whole patient. Finally, looking ahead, what's new or emerging in research? Where might things be heading?
Research continues on several fronts. There's still work trying to pin down the exact etiology at a cellular level, understanding that might lead to better prevention or targeted non-surgical treatments. There's a lot of focus on optimizing current treatments. For example, are there ways to make aspiration more effective, combining it with longer splinting, or perhaps injecting sclerosing agents? The evidence is still evolving there. Surgically, refinement of techniques continues, especially arthroscopic methods, aiming for lower risks and faster recovery. There's also interest in whether addressing associated issues, like subtle ligament instability, at the same time as cyst excision might reduce recurrence rates. Some research is exploring alternative therapies, like electroacupuncture, which has shown some early promise in small studies, but we need much more robust evidence before recommending such approaches routinely. And perhaps most importantly, ongoing work focuses on improving patient education materials and decision aids, really fostering that shared decision-making process we talked about, ensuring patients make choices that align with their own priorities and values.
What a fascinating and detailed deep dive into ganglion cysts. We've gone from understanding that balloon on a stalk right through to the nuances of surgical technique and the importance of patient perspective. It really highlights how these common lumps deserve our careful, expert attention.
Indeed. I think the key takeaway is that even conditions we see frequently require a thorough, evidence-based approach. It's about combining good clinical assessment with an understanding of the underlying issues and the pros and cons of each treatment, always tailored to the individual patient sitting in front of you.
Absolutely. And that brings us to the end of this deep dive. Thank you so much for joining us. We really hope this discussion leaves you feeling well equipped and confident in managing ganglion cysts in your practice. If you found this deep dive valuable, please do consider rating and sharing it. It really helps other professionals discover these insights. And finally, something to perhaps mull over in your own practice. Given their sometimes unpredictable nature and those persistent recurrence rates, what do you think might be the next frontier in truly understanding, perhaps even preventing ganglion cysts beyond our current knowledge?